quick introduction. I'm Marilee Benson, President and co-founder of Zen Healthcare IT. Welcome to Marilee's office hours. For those of you who are new to this session, what we like to do here is talk about new events happening that affect health tech and in particular interoperability. If you're a stakeholder, whether you're a health tech founder or executive or technical resource, or you are an HIE or a provider group or any sort of other stakeholder in healthcare, obviously sharing data is super important. And so we want to highlight everything happening because there's a lot of change happening right now. And that really is about what today's session is about, just because there's been so much news coming at us so fast. So for those of you that haven't heard me say this before, please, if you can, turn on your cameras. We love to see your smiling face. Mike, that's it. I'm talking to you. Thanks for turning your camera on. Appreciate it. That way I don't feel like I'm talking to myself. And we'll go ahead and get started. And also take a minute to introduce yourself in the chat. So let's get going. So we are going to talk about a lot of things that are happening in the health tech and interoperability space, covering things like what happened, what's going on with CMS Access. The first applicants were announced. Let's learn a little bit about them. We now have the ability for health tech vendors to apply to the CMS, to be in the CMS Medicare App Store. What's that? A CMS provider directory was just recently rolled out. What's going on there? There's lots of changes in TEFCA. And then we have this interesting CMS or ONC data standards, rule making and rule drafting happening. And the way I'm framing that is it's the battle of the data standards because there's not a lot of consistency happening, but welcome to one foot on the boat and one foot on the dock, as we are in healthcare interoperability right now. But first of all, I'm going to do a quick a sneak peek. We sometimes in our monthly webinars, we definitely, these are not commercials, but we do say that we are sometimes sponsored by different things, different companies, or different solutions that Zen has. And the main reason I wanted to show this is because for 10 years, I've been talking about the fact that Zen as an interoperability platform is middleware. And we didn't ever have a, nice web UI because, it was mostly engineers using our software. They're used to working in engineering focused tools. But as what we have done has really evolved significantly over the last 5 years, all of a sudden we started to see a need for a UI. And so the first one that I just want to highlight here today in this session, for those of you who are doing National Network Exchange, you may have experienced what it's like to have to download a spreadsheet in order to know who's in the directory. And we felt like that was a problem that needed to be solved. So for all Zen National Network customers, or for anyone who is engaged in National Network Exchange, we are making this dashboard available. If you're not already a customer, at a very reasonable cost, and for customers, we're just making it as part of our offering that customers are already using. So one of the things that we're doing here, number one, you can see the differences in the network adoption here. Our customers are representative of each one of these networks, so therefore our customers who are multi-network participants are able to see the information across the networks that they're participating in. And if you're managing something like a delegation of authority use case, or you just want to know, who the data sharing partners might be in your area, or look up a specific organization to say, are they on the network? What network are they on? And how are they on the network? That's what this is really designed to make easy to do. So for example, if I type in Sutter Health, I can see that, I see Sutter Health here under eHealth Exchange. I also see them listed in a number of other places, with both at the parent level and at the child level. I can see they're participating in TEFCA. I can see, there's Sutter Health Affiliates that is actually a Care Equality participant. And here's all of their children or additional sites that might be associated with them. So lots of helpful information, the ability to quickly see the OID, which is their unique identifier that's tied to them when you're doing something like a delegation of authority form that you might have to fill out. So that's all I'm going to show you. I promise just a quick peek. trying to build some awareness. And I want to thank the customers that are beta testing this for us. Really appreciate the feedback. Command Center has a lot of other capabilities, including alert and monitoring and the ability to support smart on fire connections kind of out of the box. So if you have any interest, throw a comment down in the chat and we can get back to you and do a demo. Okay, let's get started with what's going on right now in the world of interoperability and health tech and CMS, all things CMS as it impacts health tech. So the first thing that exciting that kind of happened is we had this first group of CMS access applicants announced. And I got my whiteboard out. I did a bunch of research, leveraged some great information that some other people had put together. In particular, I think the one that I found most valuable was this Thoughts on Healthcare Substack, which you do have to have a subscription. So I've kind of given you a summary of what information they shared, but I gave you the direct link in case you're a Substacker. But let's look at my whiteboard analysis of kind of what jumped out to me and to some of the other folks that I was reading that also published some observations. So just a quick reminder, the CMS Access Program has been rolled out for Medicare. It's a way of trying to drive the adoption of tech for improving outcomes for certain high-cost chronic conditions. So for the first round, the condition tracks that they identified was early cardiac, kidney, metabolic disorders, and then I guess not early cardiac, kidney, metabolic disorders, musculoskeletal, and then behavioral health. So those are the 4 tracks. And then the applicants had to be Medicare Part B participants and either providers or an eligible service provider. And they had to agree to certain terms and conditions. I'm not here to talk about all those terms and conditions because we've done that in the past and we can circle back on it. What we were all really interested in, because it's definitely an at-risk type program, was who would step up and apply, particularly in this first round, because when the applications opened, the compensation model hadn't even been fully released. So this first group, I think, are brave. They have now released their participation rates, but this will be interesting to see what happens. So in general, what I think me and other people noticed is there are a lot of people who did apply for multiple tracks, really positioning themselves as a whole person chronic care provider. Some of the other things that are interesting is that MSK, which is the musculoskeletal kind of chronic pain group, is often paired. You'll see it paired with the cardiac, kidney, metabolic, or behavioral health. And at first glance, it's kind of like, oh, those are different. But then when you think about it, it's like, well, wait a minute, chronic pain often intersects with those patient populations. And certainly, chronic pain can reduce exercise and, increase functional decline, increase depression, and basically increase bad outcomes. So it's an interesting, I think it was an interesting group of tracks that was smartly put together, and then an interesting group of people that applied. So first of all, I want to call out that and I guess not unexpectedly, but I felt like this, I was surprised that there were a lot of consumer and wellness brands in the mix. People like Weight Watchers, Noom, Whoop, Withings. Obviously, some of those folks have very strong consumer brand focus already. And so they're able to kind of leverage that. And then some of them have literally remote patient monitoring, and that can be very important when we're trying to do very efficient chronic care management. And so, you have this interesting mix of traditional medical practices that have a focus on, kidney care, cardiac, behavioral health, or chronic pain management, as well as, health tech companies, essentially, or digital health. So I highlighted this very large group. I mainly just put this here just so you can see how big the list is on the left here in green. Those were people that applied for all of the above, so all 4 of those tracks. called out a couple of examples of the consumer wellness brands. And then also there was a really good analysis in the article that I shared about who's best positioned to be successful. And the way they framed it in the article was people who are already kind of scaled virtual first entities that have already a focus on EKM and ECKM specialties, and it represents where a lot of the cost savings is, and they probably have the best opportunity to actually meet the performance requirements, because maybe a little bit of behavioral changes or improved monitoring could maybe really make a big difference in terms of their HbA1c, their blood sugars. I'm talking too fast, and other aspects of outcomes for these different tracks. With what I did here, and we'll make this available for folks, was kind of look at, okay, well, they've obviously got a strong position of success. Can they really do the next step to be successful in this? Can someone like Noom, which has a strong consumer presence, crack Medicare because they've not been dealing with that population before? Maybe you've got some people that have the integration side nailed, but can they execute on the actual, chronic care management or the clinical side? So very interesting to see with some of these groups, maybe they seem to be well positioned for success. Will they in fact be successful? We have some people that are only in the behavioral health space, which again, I think is kind of a mix of traditional and virtual first groups. I had a couple of these that if you're like me, I was like, who the heck are they? So Attune AI, Nudie, that was a new one, Slingshot AI. So I kind of did a quick look up to see what they were about. And then of course, just, it can be a little confusing because in order to be on this list, you have to be a Medicare Part B provider. So how the heck does a digital tech company make the list? Well, you quickly create a provider group or tightly partner with one, or maybe you squeeze into this pretty narrow window where you fall under a Medicare Part B supplier list, but you're not, because DME is not allowed, labs are not allowed, and so there was just a very small group of suppliers that could sneak in there as a supplier that wouldn't fall under DME or lab. There were a couple of ones that were interesting. When Goji was first announced, they weren't associated with the track. That's now been fixed. And then it's also interesting because they're listed as Goji Pharmacy. Well, that seems weird, but when you look them up, they're really their website. They're a chronic care management program. They sell to FQHCs, so then that starts to make a little bit more sense. I don't know how to pronounce this. Hygiene Professionals apparently does health screening kiosk in the Delaware area. Seems like a big leap. Maybe there's some stuff going on there that we're not aware of. And Castlight has a history in healthcare benefits, and then a word that I didn't finish typing there, and health engagement for more employers and payers. So some really interesting people on the list. And I'm going to go back to the audience because I'm really hoping that someone might also have reviewed the list and have some comments that you might want to throw out there. Did anything surprising hit anyone when they reviewed the list on their own? No, Mike says no. Mike was not at all surprised. Okay. Well, we will keep going then. So that's the access group. When we share the PowerPoint with you, you will get the article as well as we'll give you an extract of the whiteboard. And I'll add the list of the accepted applicants so that you can just have a one-stop shop on that. The other thing I want to point out, and I'm sure some of you have read this, is that very quickly after they announced access model only being really applying to Medicare, they also talked about the fact that they were creating a voluntary model and encouraging private payers to also put together a similar program. And so we have had private payers representing 165 million members across Medicare Advantage, Medicaid, and commercial coverage have already committed to aligning with this payment approach, with many actually starting that this year. So I think the lesson here is that it may not just stay with Medicare. There's going to be a lot of experiments, and those experiments are leaning into how health tech can improve outcomes, and interoperability is a critical prerequisite, which is why I care about it. And I know a number of you, like our HIEs over at folks like Reliance, care about it because it is going to trickle down to all of us. All right. The other really cool thing that just got announced, we knew it was coming, but they finally got the website out about it, is they are launching a Medicare app library. So the goal here is for those of us who are on Medicare. I don't know, I see at least two of us on this call that are on Medicare. You can, when you go to the Medicare website, you can see that there's a list of kind of already authorized digital health apps that fall in certain categories that CMS has deemed really important. So let's take a look at where they're starting here. So if you are building a digital health app or these other kinds of apps, you would qualify if you're doing one of these three things. I would say there's a couple of common requirements, and that would be doing identity proofing through ID.me or Clear or one of the other eligible CSPs, and also engaging in healthcare data exchange with a CMS aligned network. So those are all kind of common across all these apps, but their focus initially is on consumer facing digital health apps that can retrieve data from a CMS aligned network and then share data via FHIR, via Blue Button, they've got these concepts of the smart health card or smart health link. And there's a direct tie-in to the CMS March event, the CMS Interoperability Framework March event that highlighted some of these, showed you some real world connected technology doing this kind of data exchange. Also conversational AI assistance. They have some specific, AI requirements there, but you can kind of see that, really the focus here, again, there's a common theme here, managing chronic care for people that have some of these chronic illnesses. And then again, diabetes and obesity management, all again, kind of associated with the same theme across all these different programs. So even though they all kind of seem like different initiatives, there's very strong management of these chronic conditions that is the common thread that weaves all these different initiatives together. Also looking, again, taking a quick glance for questions. Any questions or anybody that has thoughts on the App Store? I expect that I will be getting some questions from some of our health tech vendor clients in very short order on that one. All right, we'll move to the CMS Interoperability Framework. So when that framework was announced by CMS, they talked about kind of showing results on an interim basis. And the first milestone was in March to say, let's show real world examples of these initiatives to the world and show that voluntary company, even competitor participation and partnering to demonstrate that we can really make this work and move faster works. And so I actually put the link to the event. It was recorded. I highly encourage, if you have an interest, to go through and watch the event. You can kind of speed through the things you're not interested in and get right to the demonstrations. And I did not highlight all of them here. I just kind of picked the ones that I thought were most interesting to me. Several organizations showed this concept of a digital insurance card using CMS Blue Button, where the digital health apps can connect via Blue Button to CMS. And then the healthcare consumer, after having done their identity vetting, can pull a digital copy of their insurance card. And then the idea is the EMRs will be able to scan those and share data with their providers. We also had an example of data sharing for individual access services with BeWell and DaVita. And this is a very interesting experience. This was particularly interesting because you would have or I would have expected this to be done via TEFCA, but DaVita is not yet a TEFCA member. And so for purposes of the March demonstration project, it actually was kind of a lot of networks coming together. You had BeWell, who's a member of Commonwealth, who's a carrier quality implementer, connecting to eHealth Exchange, who's a carrier quality implementer, to DaVita, who is an eHealth Exchange member. So I think you can see how important this cross-network data exchange, these relationships are. And they were able to, for purposes of this demonstration project, make this work. I will say, just a cautionary note here, I don't necessarily expect to see a whole lot of patient access or individual patient access happening yet through carry quality. TEFCA is the way to go. It works out of the box today with TEFCA. There were a lot of kind of special things that had to be done for some of these demonstration projects, as you can imagine. But I can tell you that it was a good example of where people were going, oh, wait a minute, maybe we can build on the success with TEFCA and kind of, make this operate on different networks, whether it's carry quality, or some other private network where just a group of people have agreed to exchange data together. And that is important to CMS. It is the reason why they didn't pick a TEFCA only strategy for their CMS Interoperability Framework. Whether you're an HIE, a regional health information exchange, or whether you're a big national network, you can implement these strategies across the board. Oracle and Clear did a cool example where they used the identity validation with Oracle, again, with this whole concept of identity vetting and the ability to do a record sharing exercise without having to have a EMR tethered portal in the mix. So that was cool. And then they highlighted the release of their CMS provider directory. That is using something called FHIR. When this first came out, they had massive files available to download. I will tell you those as of this morning were no longer available. So I'm guessing they might have had a little hiccup or they're doing a big update or something. But before that happened, there were some folks doing analysis, and just to give you an example of the information that is going to be available via that new updated CMS provider directory, 7.4 million practitioners, 3.6 million healthcare organizations, 5 million FHIR endpoints, which is fantastic. So for us, we were super excited about the FHIR endpoint and related and connected to the health practitioners and the healthcare organizations. We have some ideas. So stand by for more to come on that. But I just think that for many of you, you've probably been frustrated with the state of the MPPS provider or database that I see Mike nodding your head. Sat out there, bad data quality, wasn't getting updated, and basically just, not being a functional tool for folks to use. And this is a huge step in the right direction. They are being incremental, and at the stage they're in now, what they are asking for is for folks to engage with the content and let them know where the problems are, how can they do it better, look for data quality issues, and a full court press on trying to make it be really if not a one-stop shop, certainly being an important source of data for things like FHIR endpoints, which really there hasn't been another good way of doing that. All right. Pausing for a glass of water. Any comments, input? This is a quiet group today.
Well, I'm going to jump in while you're taking a quick
Go for it, Jim.
Drink of water here. I just put a quick question in. Actually, I didn't form it as a question, but it is a question for the group overall. We are looking at, as Marilee intimated there, at including the CMS provider directory information, especially the FHIR endpoints, into our directory services that Marilee showed at the very beginning, and really seeing if we can continue. Yeah, there you go. You did out of command center there, to see if we can establish a a directory of not only those, but also the TEFCA and other national network directories. And I'm really curious with this group, to what degree do you see value for yourselves with that? Is that something that would be valuable? And so you've got a one-stop shop. You don't care. What are your thoughts? Please either speak up turn your microphone on, or give me a quick response in there if you can, in the chat if you can.
Well, I can tell you that my supervisor was using it just the other day to try to look at all the sub participants and who's querying us over eHealth Exchange and all that stuff. So we have found it valuable already as beta testers.
Thank you, Mike. We really
I
appreciate
think
that.
Sunny got the notes on all those when we met with them earlier.
Oh,
Awesome.
that's great.
Awesome. Yeah,
Yeah.
and you know, we think we're increasingly in a world where we have to understand that there's going to be many ways to share data, and one of them is certainly an important one, are all the different national networks exist. But another one is direct FHIR endpoints that are available and mandated. And they're finally kind of starting to mature a little bit. And as we move through more updated versions of FHIR, and we move from a world where we had really limited data with USCDI version 1, so the scope of the data was pretty small. That scope of that data is now bigger with USCDI v3, and we're hoping that CMS will continue to push folks to continue to share more and more clinical data through both FHIR and CCDA Exchange, so that again, we can just have many more effective options in terms of data exchange. So we appreciate your thoughts. If you think of something later, don't hesitate. And yeah, Jim, thank you for that. All right, moving on to TEFCA changes. So my favorite website page at the RCE is the TEFCA changes under consideration. And because Zen is a TEFCA participant and we advocate a lot for TEFCA and other network participation, I kind of feel like it's my civic duty to make sure everyone is aware of the changes that are awaiting your comment. Because there's really a level of transparency over the last year that wasn't always available with TEFCA, and so we want to take advantage of that. So we will quickly drop in here. The first one is this concept of know your participant. I am sure that many of you are aware of some recent lawsuits where some large health systems and provider groups have sued other entities that are participating in national exchange, so that because they felt like people were violating the rules, and that they were maybe making treatment queries when they really weren't providing treatment services, just to give you an example. And so one of the ways that we can keep those bad actors from being on, any particular network, but particularly TEFCA, is make sure that the QHINs, when they're onboarding new participants, are doing enough background assessment of each participant. And so even though there was some, I felt, pretty good vetting already in place, because there was an alleged issue, they wanted to take another swing at it, and that's what this proposed change is called Know Your Participant. I will say that those of you who have an interest in this, it is very important to go and let your voice be heard, because they are significant changes. It does put a large share of responsibility to QHINs, and I would say that rolls downhill to people like Zen and anyone else who is onboarding and vetting new participants as a parent organization, if you will. It requires a lot of specific business information to be gathered from any organization participating in TEFCA-based exchange, whether you're a health tech vendor or whether you're a provider. It tightens up what qualifies as evidence of being a covered entity. So this actually makes provider participation a little bit more challenging. Not every provider organization is technically a covered entity. If you had a concierge medicine, for example, and you're not taking any insurance, then as far as TEFCA is concerned, you're not a covered entity and you can't participate in TEFCA.
That's what I was about to ask you about.
That is a problem, Mike. It is a problem that Carry Quality, while it references the HIPAA rules, hasn't took such a strict view of what the definition of a covered entity is. TEFCA has taken a very strict view. And I would say this is even more strict, because under the current TEFCA vetting requirements of covered entity, there were multiple ways that you could prove you're a covered entity. And I'll give you an example of one. You might be concierge medicine, but you might be coordinating care outside your practice because you're sending them for lab or radiology or to a specialist. And so you, because of that, and because you're high value to your patient, you were checking eligibility, so you knew the insurance. So you are engaged in a HIPAA transaction. If you're engaged in doing an electronic HIPAA transaction, by definition, you are a covered entity. At least that's the way most people think the rule works. This one tightens it up so that the only evidence is claims, the fact that you've got reimbursed from a payer. And so the feedback that the community is starting to give folks is, hey, did you purposely mean to take one of the HIPAA standard transactions off the table? And the answer is, well, no, we just forgot about that one. So it'll be very interesting to see if what kind of red lines. I think we're going to get a lot of red lines on this one, or another version, but we'll see.
So
Yeah.
are the stakeholders who are in these committee meetings and stuff, I cannot remember what the makeup is, but is there any representation to help further the visibility of those groups that they tend to forget?
So, Mike, I'm not in those conversations, but let's just talk about it at a high level. So you have the RCE, you have CMS, you have the RCE, and you have the QHINs. The QHINs work with each other. And of course, they represent EMR vendors, they represent private health information exchanges, like commercial entities like Health Gorilla, SureScripts, and then Commonwealth, which is in a health exchange, right? So it's a pretty diverse group of people, but they're not necessarily a lot of provider groups represented. Now, there is a participant subgroup that they're forming, and that exists. I don't know how much input that particular group got to this proposed change. One of the things,
Well, especially if they're going to be cutting people out of the participant group, those are the people that are affected.
Right.
Agree 100%. And this whole concierge medicine, not just concierge medicine, by the way, also free clinics, right? Kind of on the other end of the spectrum. That has been known since day one, and there has been a lot of pushback. And so if you look at someone like No2, that's a QHIN, they do a ton of work with long-term care. The long-term care isn't always, those folks aren't always getting commercial insurance. And so this has been an ongoing debate. I was surprised when I saw this to see that instead of opening it back up, they're actually accidentally or not thinking about making it even more narrow. Again, I think that what I'm showing you here are proposed changes. I suspect the next rev will address some of these issues. Yeah, because you're right. It is a problem. And it's also one of the reasons why carry quality, people say, well, I don't understand why carry quality isn't going away faster and TEFCA isn't growing. And TEFCA is growing pretty quickly. But a big reason carry quality and the other networks like eHealth Exchange and Commonwealth aren't going away is because of these kind of impacts, right? So there's a whole group of very important healthcare stakeholders that are sharing data under carry quality, but right now are blocked from TEFCA. Even a significant portion of Athena Health providers, didn't meet the criteria initially because of the whole commercial insurance or Medicare and Medicaid requirement. So this was, yeah, go ahead, Jim.
I was just going to say, although it does seem like a pretty strange thing for them to have made a mistake on.
Well, the mistake on the concierge medicine and some of these other groups, I don't think it was a mistake. I think that was due to some large health systems with big EMRs carry a lot of weight in the discussions, and they're very risk averse. And so I think that's number one. So there's definitely, competing interests happening in these kinds of groups that come together. Mike also just mentioned correctional health providers. That's a great example, Mike, of people that don't want to be left out. I will tell you that there are a lot of people advocating for fixing these specific holes. I think what they're trying to do is make sure when they fix that hole that what other things are they putting into place. They want to make sure that anyone who isn't technically covered under HIPAA, and if you're not a covered entity, the argument is you're not covered under HIPAA, even though those provider groups would argue with you because they think they are. And in a lot of states, by law, they are, right? Like they're literally in Texas, there's a law that says if you're providing any sort of patient care, regardless of your whether the federally you fall under HIPAA, from a state perspective, you do. So it's very interesting. And that's a really good list, Mike, there. Thank you.
Yeah.
So that's your participant. So again, the comment period is open. Please comment.
Do you have a link to the comment section?
I don't, but I'll add it before I distribute this. Thank you, Mike.
Perfect.
Good question. Jim and Karen, if you'll help me remember that.
Yes.
Follow up. Add some of the missing links here. All right. The other one is individual access services. And this is another one where there is really a wrestling match going on between the big health systems and the individual access services providers and the consumer groups. The change being suggested, most of these changes are coming from Epic's requirement of double credentialing, double authentication, where you do ID.me or clear to validate you are who you are. But for Epic, you still have to, even when you find them on TEFCA and you jump through all the hoops as a ISP or individual services, individual access services provider, the patient still has to also authenticate into MyChart. And that's a serious bump in the road for widespread adoption and success of individual access services. So a lot of these changes are to try to move large influential health systems to stop making that extra authentication layer a requirement. And so a lot of these changes are coming from trying to manage risks that are being communicated. We're worried that the wrong person might get someone else's data. So they're worried about liability. So there are changes have already been made in terms of patient matching algorithm. Demographic double check is proposed language, which basically says that even though a request went out and was matched and information is coming back, that if that response includes patient demographic data that would cause that don't match the access, the consumer app, like they have to double check that there's another, think of it as a reverse EMPI check back when they get the message. So it's a little complicated. It's not a very viable change, and this one's getting debated. I think that what my suspicion is there is that the QHINs are going to ask to do that, to be the people that can do that on the behalf of the consumer apps, as opposed to making each consumer app do that step. And then there are some reporting requirements of what happens if that demographic double check fails, or if if an individual really does report that, hey, that isn't my data. And obviously notification about a mismatch is very important. People are very concerned about the times that this demographic double check might fail for one reason or the other. So again, this one, it is proposed. I expect to see a lot of changes. It also establishes a path to this concept of this no extra portal login. And I would encourage you, if you have an interest, to go actually read in the change management, these proposed changes, the details of them. But it's a long path. And so as far as I can tell, the IAS providers would have to do their changes well ahead of when the responders would have to do their changes, which is all the way out to August of 2027. So that's a really big gap. Seems like kind of a bit unfair. It's like if we're trying to stop barriers, and we're trying to get barriers to be dropped, it feels like those timelines should be the same. You know, we're going to do this and you're going to do that, and it's a win, and we all win at the same time. So I'm a little bit concerned about that timing gap. Any questions or comments on that? And I'm just giving you a quick overview so that if you have interest, you can kind of go in and dig in and read those yourselves.
Mhm.
The last piece, and this was really interesting because you might be, what do you mean this didn't exist before? There's a draft policy or SOP for consequences for QHIN non-compliance. So previously, apparently, there really wasn't anything in writing about what the RCE could do if a particular QHIN was not following the letter of the agreement or the various SOPs for the different exchange purposes. And so this language is designed to allow for some enforcement to happen if the QHINs are not following a particular written SOP or are otherwise violating the TEFCA trusted exchange terms. This is one I think that cuts both directions. This is both, you know, can we make sure that a QHIN doesn't put some extra barriers in front of a use case that no one else is doing, which, you know, just kind of breaks things right out of the gate. And then it also, I think, is trying to address things where you have a trust problem, like some of the lawsuits. You know, maybe the reason why we got a lawsuit right out of the gate that involved two QHINs, one, you know, each pointing fingers at each other, is that there was no enforcement mechanism or there was no formal way of dealing with that dispute internally. The Carry Quality does have a very robust dispute management process. And so I was a little surprised that TEFCA did not have that, but this is fixing that. So again, it's an interesting one to read. It gives the RCE quite a bit of leeway, and I do think that's probably important. It's not super prescriptive, but it does give a lot of examples of the kind of things that would constitute non-compliance. All right. And yeah, there's more. I just have two more slides left. And then I want to open it up for just any question that anyone has. So I talked about the roller coaster, and certainly part of that roller coaster is just so much news coming from so many different places right now. But one of the other ones I thought was interesting was two things that were announced within like a day of each other. And in one case was kind of like, okay, we are taking something away. And then the other case, it's like, but we're giving you something instead. And so CMS wants to change the way, this is for digital devices. It wants to change the way digital devices that are classified as breakthrough devices are paid. And up to this point, there was some special dollars associated with these breakthrough devices, without necessarily requiring that they are really providing better outcomes. And so they'd like to end that. But what they're going to do instead to kind of be the thing that they're going to give you is if you are one of these breakthrough devices, one of the big problems is you can get your FDA approval, but you can't start your CMS approval for Medicare until you're done with FDA. So it just takes years for someone for a digital device, a breakthrough digital device, to be able to actually get to the point where they can get reimbursed by Medicare at all. So they said, well, we're going to take away these special extra payments, but we're going to coordinate better between the FDA and CMS so that these devices qualify for Medicare payments faster when they're eligible. So these are both proposed. They're looking for comments, but I just thought those were interesting. Finally, we get to the battle of the data standards. So we had a final rule, and I am not, by the way, I know CMS has all these codes, you know, like 0053. I don't like numbers. I'm just referring to them functionally as to what they do. So if you're associated with all those CMS, you know, numbered specific rulemaking, I'll have to let you do your own math there. But they did finalize this had been sitting around forever in a draft mode. They did finalize attachments for claims so that those can be done electronically as opposed to being done via fax and manual methods. And they did settle on X12. Not a surprise. because that's how claims work today. And so, yes, it's an old legacy data standard. They're not trying to force claims to go down the FHIR route yet because there's just not enough uptake of claims being done under FHIR. I think this was a great example of one foot on the boat, one foot on the dock. And so for that use case, they did settle with what really represents real world data exchange for claims today. And so there is now a way of attaching, putting attachments on X12 files to provide that medical documentation needed when that attachment is needed to get the claims processed. Now, moving over to the other side, we have pre-authorization. We have a couple of different things happening, non-drug and drug pre-authorizations. For non-drug, they are proposing, and honestly, I don't remember if this is final or draft, but they are settling on, and I don't see this changing, for non-drug pre-authorizations, FHIR under the Da Vinci project, which I think is great. But when we get to drugs, you know, we live in such a complicated world when it comes to how drugs are dispensed and paid for, that we broke them into two categories. Medical benefit drugs, so drugs covered under the medical benefit, that might be something like an IV drug or something, is going to be FHIR Da Vinci, same as the non-drug. But the pharmacy benefit drugs is going to stick with the way it works today in the real world, NCPP and something called RTPB, which is real-time pharmacy benefits standard. So all the standards, I my favorite saying, Jim, is what?
They never sunset a standard, they just add another one.
That's right. That's right. We just create new ones. So this is a classic example of that. And I will say, you know, from our perspective, it's the reason why we put a big focus on bridging across these legacy and modern data standards. We have an X12 to JSON transformation service, a CCDA to FHIR transformation service, and a HL7v2 to JSON transformation service for a reason, because we all have to live in a world where all of these data standards have to coexist. Oh, and Mike has given me a comment.
And it's a good one.
I love it. We'll snap that and I'll put it in the PowerPoint and put the link in there so everyone can enjoy it. Mike, thank you for that. All right, we are in wrap-up mode. I am just open, you know, table topics. Who has something that they've seen interesting happening in the world of health tech or healthcare interoperability that you want to make a comment on or ask a question about? Everyone, like I said, other than Mike is very quiet today.
I'm trying to do my best to help out.
You did good. You did good. Yeah. So it just depends. And I definitely see people who are here routinely, which I do appreciate. Those of you who are frequent flyers, and for those of you who are new, thank you so much for joining us today. You never know. Sometimes we get into quite interesting debates. I know Elizabeth. We had a call recently, one of these where you and I got into a quite robust debate about what was happening with the individual access services and Epic and some of the other big EMRs that sometimes can throw some barriers in there that can be quite frustrating for everyone. I will say, I just think to leave everyone with this, you know, I don't think, or my sense is that people really are trying to solve problems, and large health systems and providers really do have concerns, and they are risk averse for a reason. And even though it can be frustrating, you know, the whole point of healthcare data exchange and these trust frameworks in particular is to build that framework where we can come together and we can agree on these checks and balances that enable progress. And it, you know, I think the last reporting out of care equality was 1.3 5 billion clinical documents exchanged in 1 month. That is a phenomenal number. TEFCA is growing rapidly in terms of the number of participants, but so I think it's actually growing more rapidly than carry quality did back in the day, which is not a surprise. And I'm particularly excited about the fact that we're starting to see more situations where people are instead of it all being about mandatory exchange purposes like treatment and individual access services under TEFCA specifically, it's starting to be about, oh, we can also do pick your own trading partner exchange at scale. And that framework, I think one of the things TEFCA is doing well is establishing a framework where you have a lot of pretty specific use cases that aren't necessarily mandated, but enough, and we get critical mass where there's enough people able to participate and willing to participate, even though they don't have to participate. And I think a good example of that is what we saw where we had a patient access query happening through carry quality, even though that's not a mandatory use case there. And who knows what might come from that. And I'm excited to see where we go with payer and operations use cases as we go through the year here in TEFCA. And I can promise you, if I see something real happening, you will hear about it in one of these monthly sessions, because that's going to be a lot to celebrate. And by the way, I just want to acknowledge, I think the regional HIEs, like our friends Mike at Reliance, have such an important role to play in helping that payer and provider data exchange. And you're really showing the way forward, and you're able to solve problems, that trust problem at a community level that is certainly challenging at the national level. So you are a very important part of that puzzle, for sure. All right. Any final thoughts from anyone? If not, I will make sure I add these links in. I really want to thank everyone for joining the session today.